changes, which when taken together clearly represent a disease entity, regardless of the disease that started the process.
The clear implication of all of this summit, the effort that you've put into this message, is that mainstream medicine does not treat pain well. Is that the case?
That is absolutely correct, and it really goes right across all categories of pain, from acute pain, say after surgery or trauma, to chronic pain and also cancer pain. The evidence is very, very clear.
Well, why is that? I would have thought it was a fundamental role of a doctor to take pain seriously, that the treatment and alleviation of pain is absolutely at the heart of medical practice.
It should be the primary role of every doctor, and indeed, I think it should be at the top of the list of human rights. But what has happened, unfortunately, is people haven't understood this fundamental difference between acute pain and chronic pain. And with chronic pain, you need a team to assess the various components of the problem. And this is just not happening, except in a very, very few chronic pain or pain management centres.
So when you talk about cancer, as a for instance, in what way is pain overlooked as a part of the treatment of cancer?
Well, it's not overlooked, Kerry, but there's a tremendous emphasis, of course, on the treatment of the cancer. And there's a lot of evidence that patients don't really want to trouble their oncologist or their radiotherapist with discussion of their pain. They want them to focus on the treatment of the cancer. But it also arises from the fact that pain has been assigned a very low priority. Chronic pain, and this includes cancer sufferers, cancer survivors really suffer from chronic pain problems, many of them. Chronic pain has not been on the radar as a health priority, but it's the third most costly healthcare problem in this country. So I think it would be fair to say that people with chronic pain are discriminated against because they don't have access to the same facilities that are available to other chronic disease sufferers like diabetes and others.
What do you say about children with regard to the treatment of pain? Because I know that you regard this as a particular problem.
Well, it's a shocking situation, Kerry. Today, the first major study of unrelieved pain in children at the end of life was published in the Medical Journal of Australia. Quite an incredible coincidence on the very day of the Pain Summit. 43% of those children suffered from unrelieved pain. This is a study from the Royal Children's Hospital in Melbourne. Now, I think that's a shocking and unacceptable statistic. Even worse than that is the fact that we now know from overseas studies that about 20% of children have chronic pain, chronic non-cancer pain, such as migraine, recurrent abdominal pain, etc. And that is extremely poorly managed.
Are they just not taken seriously? Is this the case that
Yes.
patients, whether they're children all the way through the age groups, are just not taken seriously enough too often when they complain of pain?
Absolutely, Kerry. They're stigmatised. There are a lot of myths that abound in the general community, and I'm afraid to say this across the medical and healthcare profession also. And a lot of these people are subjected to not being believed, to implications that they are trying to seek opioids, and even worse than that, that they're an opiate addict. And basically they finish up receiving very unsatisfactory pain relief. One of the speakers at the summit today was Kieran Perkins, whose wife has severe migraine. Now, you'd think that someone with his ability to know what's going on in the community, that his wife would be able to obtain effective care. But many times she's presented to emergency units and be treated as if she was an addict, and I think that's disgraceful.
By the same token, you'd also acknowledge that doctors do have to be concerned that their patient doesn't end up addicted to painkillers.
Oh, most certainly. And the important point to make there is that there are a very wide range of treatments now for chronic and cancer pain, including opiates, but many others too. And what we really need is for patients to get access to that wide range of treatments. And as I said earlier, they're being discriminated against inadvertently because we don't have the resources to provide that access.
Is there a concern about people self-administering their pain because they either don't want to complain to their doctor, they don't want to see their doctor about it, or they don't have faith in mainstream medicine to treat it or to take them seriously?
I think a lot of people start to become demoralised. They get the message that nobody's interested, and they start to go down a spiral. And this is part of the disease process. They get depressed, they get anxious that this is going to go on and how will they cope. They get to the stage where they decide that nothing is going to be done, and then they lose hope, and that raises the spectre of suicide. Now, we don't know how many chronic pain patients commit suicide in Australia. We haven't done the study, but overseas studies indicate that it's quite significant. And sadly, I've had a number of my patients who have done just that because we were unable to help them.
If someone is in pain, what is there to be done about it if it's taken seriously, other than providing appropriate painkillers, whether it's short-term pain or long-term pain?
Well, for short-term pain, we do use medications a lot, of course, following surgery and following injury. But even there are good psychological and physical strategies that can be used. But in the patient with chronic pain, we now have a wider range of treatments. And they start off with self-help programs that can be used in the general community. There's a pain condition called complex regional pain syndrome that results in the individual being unable to use an arm or a leg. Now, this is due to changes in the motor cortex of the brain, and there are now physical therapy techniques that reprogram the brain. In other words, they teach the patient to relearn how to move that limb. And then there are, of course, a wide range of pharmacology, but the new pharmacology of pain is targeting the changes in the central nervous system, a whole new range of disease-specific drugs, not just morphine and aspirin, a very, very exciting area. Then we have what we call interventional techniques, neuromodulation, spinal cord stimulation, stimulation of peripheral nerves to harness the body's own pain-relieving system. So they're just a few of the techniques we have available. Most people don't get access to those in Australia at the moment because we don't have the resources or the framework to do it.
But you've already identified through access economics that the total cost of treating pain is something like $34 billion a year. Isn't what you're talking about simply going to add significantly to that bill?
It's not, because people are not receiving effective treatments at the moment. That 36 million lost workdays can be reduced by half. The 34 billion cost can be reduced by half because we have techniques to do the job properly. And the cost of doing that will be a tiny fraction of the money saved. So to me, this is a no-brainer for the federal government. This fits into the new health reform agenda very, very well. And I think it should be a priority because it really should be a human right for people to have access to this sort of treatment.
Michael Cousins, thanks very much for talking with us.
Thanks very much, Kerry.
And now it's Thursday with their take on the week in politics, John Clark and Brian Dorr.
Joe Hockey, thanks for your time.
Good evening, Brian. It's very nice to be with you.
You've been on a building site?
No, just come from the party room.